Dr. Sumant T. Edited Kasturba Medical College, Manipal. I'm happy to see Manipal name here. So, currently doing 1-year fellowship in pain management in Daradia Pain Hospital. Dr. Sumant, if you're ready, can you share your screen, please?
Yes, sir. Good evening, everyone. Thank you, sir, for your kind introduction. And I'll be sharing my screen. Sir, can you see my slides, sir?
Yes, go ahead, Sumant.
First,
make it a full screen.
Yes, sir. Sir, the patient is a 44-year-old who has presented to our pain clinic with complaints of pain in the right side of chest radiating to the back since 8 months. And he had history of pain in the anterior chest area on the right side since 8 months, which was dull aching, gradual in onset, and increased in severity since 1 month, and it is radiating to right scapula, upper mid-back, and right abdomen. The severity was around 5 to 6, and it was continuous pain. It was not associated with tingling, numbness, or burning sensation, and it was also not associated with postural changes. He had a significant weight loss history of around approximately 12 kgs in the last 6 months. There was no history of productive cough or shortness of breath. He was diagnosed.
Excuse me, is it only me that for whom the presentation is not moving?
Excuse me, madam?
The
Sumant,
slide is not changing.
Yeah, Sumant, your slides are not changing.
I'm sorry, sir, it's changing in my computer. Is it changing now, sir?
Can you try full screen, please?
Make it slideshow.
Yeah, it's changing now.
Is it okay, sir?
Okay, yeah.
Yeah.
Yes, sir. I'll do it from the beginning again. So he's a 44-year-old gentleman who presented to our pain clinic with complaints of pain in the right side of the chest, radiating to the back since 8 months. And he had this pain in the anterior chest area on the right side since 8 months, which is dull aching, gradual in onset, increasing in severity since 1 month, and radiating to the right scapula, upper mid-back, and right abdomen. The severity was around 5 to 6, and it was continuous pain. It was not associated with tingling, numbness, or burning sensation, and it was also not associated with postural changes. He had a significant weight loss history of around approximately 12 kgs in the last 6 months, and no history of productive cough or shortness of breath was present. And he was diagnosed with metastatic adenosquamous carcinoma of lung, and for that he has received 12 cycles of chemotherapy and radiotherapy. Past history, there were no pain events mimicking the present symptoms. He is a known hypertensive since 3 years on telmisartan. He had history of chronic tobacco abuse for the past 15 pack years almost. And he had a history of adenotonsillectomy when he was a child. And for this pain complaints, he has been started on tablet morphine, 30 milligrams sustained release tablets twice a day. And he also received etoricoxib 90 milligrams per day, and a tablet dexamethasone 6 milligrams once a day, and injection paracetamol 1 gram on SOS basis, for which he has got only 30 to 40% pain relief. He takes mixed diet, and his appetite is reduced, sleep was disturbed, bladder and bowel habits were regular, and he had history of 15 pack years of smoking, and no significant family history. Coming to psychosocial evaluation, he complains of increased fatigue and demotivation during the day, which worsened during the periods of chemotherapy. And he worries excessively regarding his medical condition and his financial concerns. And his sleep worsened since diagnosis due to anxiety and pain in the night. And his PHU score was 15 out of 27. And on general physical examination, he was moderately built and nourished, conscious and well-oriented. Apart from pallor, he didn't have icterus, cyanosis, clubbing, or pedal edema. Body mass index was 19.2 and vitals were stable. And on inspection, there was no muscle wasting, no restriction of movements, and no engorged veins. Chest wall palpation revealed tenderness present in the right infrascapular, thoracic, and lumbar spine area. There was no hyperalgesia or allodynia, and chest wall expansion was 4 centimeters with the inspiration. Lung examination, auscultation revealed dullness to percussion and decreased breath sounds in the right infraaxillary and infrascapular areas. And cardiac examination was otherwise normal. Investigations, hemoglobin was 9.8, ESR was elevated, creatinine is 0.72, and albumin is 3.2. The latest PET CT scan revealed a right-sided moderate pleural effusion along with right lower lobe collapse. Within the collapsed lung, a hypodense nodular mass was present. Multiple enhancing nodular pleural deposits were noted in right diaphragmatic pleura. Multiple enlarged mediastinal lymph nodes were present in perivascular, right hilar, and subcarinal regions. Multiple hepatic metastases were also noted. Mixed sclerotic and lytic metastases were seen in dorsolumbar vertebra and pelvic bones.
Right. Thank you, Sumant. So we have a patient here. He's a 44-year-old gentleman with adenocarcinoma involving the right lung, who's come to the pain clinic for referred for pain management. So can I invite Dr. Rohit here and ask him, sir, this patient is being referred. He's already on a set of pain medication. Before we start, in terms of investigations, in terms of information from the history, would you like to know anything more?
Dr. Karthik, this was a very good case presentation by the doctor, but what I want to ask a few things before we proceed on with the cases. Number one is, one thing is that the patient has been investigated and he has given all the reports because he has said that the metastasis is there in the liver, the metastasis is there in the vertebral bones, a PET scan must have been done. And what I worry about is because all these investigations have been done and there is no neurological neurological effect as in, because no allodynia, no neuropathic pain component as such. One thing very important I just wanted to know is that morphine had just been started 30 milligrams sustained or controlled release. What was the initial dose that the patient was started with? And how he was managed earlier. Number one, because again, if we go with the all history, he still doesn't have a very good pain relief right now. So I just wanted to know about what was the initial dose that he started with the morphine, and that is basically the very important thing. And was he very empirically put on a morphine 30 milligram control release, or was it started gradually and then it was from a regular morphine and then he was shifted to this control release? That has not been mentioned here. So they are two important things that we want to discuss again here, because the pain relief is not very good. Regarding the investigations, I am very fully satisfied because they have fully investigated the patient and they have labeled the patient as an adenocarcinoma. I think further investigations are not needed as such, because they have already screened the spine, they have screened the liver. I think probably we need not to go for more of the investigations because financial constraints are there. So, and we are not going to get a lot of the things if we go for more investigations, which may not be quite fruitful to us in the sense of his financial constraints. I think I'm quite satisfied with the investigation that he has done.
Right. Can I call in Dr. Megha here? And somebody with this situation, what should your approach be in terms of clinical decisions? How do we proceed? Dr. Megha, please.
So I think in such cases, first of all, I think, I'm sorry, I forgot your name. The doctor who presented has really taken a good history, and a detailed examination has been done, which is really important. And however, the approach now would be first dealing with the physical symptoms, right, which is really distressing for the patient. First one is the pain here, and of course, a lot of psychological and financial distress is there. So we need to first thing focus on pain, right? So as I could see that the patient is on morphine 30 milligram SR, But along with that, the RSF1 analgesics have not been included. PCM is only on an SOS basis. So I think, making the analgesics, optimizing the analgesics first thing. And then we move on to, once the patient has good relief in pain, we move on to managing the patient in a more holistic way in terms of, what is psychological distress, and financial distress is really difficult depending on what scenario you're in. Like, I'm in a corporate hospital. What scenario is the patient in? Is he in the government hospital or wherever? Since the patient is already on an advanced disease, so we can counsel him to opt out of chemotherapy or not. So those things I think we need to take care of with the primary physician in loop and all the family members, decision makers in loop.
Right. Thank you. So what the panelists are saying so far is, so far the investigations that are there are sufficient, one. And second is, in terms of treatment, since this patient is referred for pain management, to go ahead with initially starting these patients on something maybe conservative, optimizing his analgesia potential. Once his pain medication is optimized, then think more in terms of psychological support and other support systems, and maybe counseling and palliative care and so on. Right. Can I call in Dr. Joyshri here and ask her, in terms of medication, considering there is a lower lobe, right-sided lower lobe collapse, and other than the adenocarcinoma in the lung, there seems to be mets in the liver and in the vertebral. So in terms of medication, how do we proceed, ma'am?
See, one thing we have to find out first is, he mentioned in his history that he has right-sided chest wall pain and pain around the right scapula. I don't think there was any mention, and there was slight right-sided abdominal pain. So in terms of medication, he is getting extended release morphine. If you feel that morphine is not adequately controlling the pain and breakthrough pain is a reality, you can add in oxycodone in between. And one thing I wanted you to be aware is, current literature, if you look at the various opioids, they talk about opioids which actually can induce or be against, or what should I say, stimulate cancer cells, versus there are some of the opioids that are safer. The opioids that are considered safer are oxycodone and hydromorphone, whereas morphine falls into the category, it may affect the cancer cells. So that's one thing. So given the situation, I would go for some additional intervention. If it is mostly pain in the right scapula, we need to determine, will a paravertebral block help this patient? Is there a role for a suprascapular nerve block or an intercostal block, which may reduce the pain in addition to the morphine? And if it is mostly predominant upper abdominal pain, you can even consider doing a splanchnic nerve block to see, provided there are no enlarged lymph nodes around the T11, T12 area. Those are two additional things you can do. The third thing is, if you can increase the dose of morphine. The other thing that I'm aware, which is available in India, is fentanyl patch. You may want to consider the fentanyl patch. Only thing against the fentanyl patch would be, like Karthik mentioned, there is some amount of pleural effusion. Higher doses of fentanyl patch can cause, chest wall rigidity and difficulty in breathing. If he is otherwise breathing okay, saturation is okay, that's another option. I don't know, last I heard methadone will be available. Is methadone available now?
Yeah, methadone is available now.
Okay. I don't think methadone will be a great choice, especially in someone who is not doing so well. But if you have limitations on the availability of hydrocodone, oxycodone, etc., you can probably try 2 opioids instead of the other. I am not talking any other major interventions because I think I have to hold my horses. Back to you, Karthik.
Thank you, ma'am. So, yeah, so what she's essentially saying is optimize the medication first. If it works, it's fine. Otherwise, think of interventions. And she suggested about 3 interventions. One of them is a paravertebral block. One of them is intercostal. Third, she suggested is plankton. All acceptable. Right. Can I call in Dr. Ashok Jardin now and ask him, considering we want to try conservative because this patient has got meds, and even if there is a role for an intervention, it may not be the ideal situation. Possibly he may have abdominal pain after some time, or the vertebral meds can start acting up. So probably in my book, conservative management may not be a bad idea. It may be better in overall controlling his pain. In terms of pharmacology, sir, is there a role for adding neuropathic pain medicine?
Thank you, Dr. Karthik. But before going into discussion, I will step back and start from the history, because treatment patient is already getting. But I would like to evaluate this patient on further 2 points clinically. First, as patient is having interscapular pain, I would like to search for the myofascial pains in this patient. I would also like to focus whether patient is having the pain from the meds which are in the vertebral body. And then I will plan my treatment. As other speakers have already mentioned, he is not optimized on the medical therapy itself. He is getting one time the NSAID, one time steroid, dexamethasone, and 30 milligram of morphine, which I think it is a moderate dose. It is not an optimal dose. So before venturing for answering your neuropathic medicine, which is very important, because with the moderate dose of the morphine, if you add neuropathic medicines like gabapentinoids, antidepressant, definitely going to help in this patient particularly, because he is also exhibiting features of depression and mood swings. So in this situation, we really, if we add neuropathic medicine, will definitely help. And then later on, we can further optimize identifying the factor, whether it is a myofascial pain primarily or pain is coming from the bone. Then other pharmacologic agents like bisphonates and other things can be thought of. I think, thank you. Over to you.
Okay, so myofascial pain in cancer pain. Okay. Okay, can I call in Dr. Samar now? Samarjit, can you hear me? In terms of opioids,
yes, sir.
In terms of optimizing opioid intake, what would you do? Would you like to increase the morphine dose? Would you like to add something else? How do you optimize the narcotic dose in him?
I think I will revise the opioid dose. If it's the starting dose of morphine, like it has been started with extended release, like sometimes we start on immediate release also. So in our practice, what we do is we start 10 milligram 4 to 6 hourly. And also for breakthrough pain, we calculate the dose and give like 5 to 10 milligram for breakthrough pain. And when we prescribe morphine, we also prescribe for its side effect, anticipated side effects like constipation. So what we have gone through the case, we did not see anything which was prescribed for the constipation, which would be into those 2 prescription I would like to add with morphine. And in this case, I think morphine dose has to be adjusted and before trying for anything else. Am I audible?
Yeah, go ahead.
Yes. So morphine dose, I would start on immediate release 10 milligram 6 hourly with breakthrough dose 10 milligram as SOS, and say tablet bisacodyl or and tablet ondansetron I'll add to the drug list.
Right. Okay. So Dr. Jordan sir wanted to know if there was any myofascial component, and Summer is saying he will start with immediate release morphine and he will give it every 4th hourly. So he's targeting a dose of to start with around 60 milligram per day with a 10 milligram SOS dose, along with constipation medicine and an antiemetic. So that I will accept. Can I call in Dr. Bablesh here? Are you there?
Yeah,
good evening. Now that the medication we are optimizing, is there a role for adding some neuropathic pain meds here?
I just want to go back into the investigation part first. I would like to go first for the ionized calcium in this patient, because sometimes, as the PET CT suggests, that the patient is having bony metastatic pain. So it is always better to check for the calcium. I don't know whether one has mentioned, I don't think so that he has mentioned the ionized calcium in that. And the second part is that I would like to check for the, because he said that the malignant pleural effusion is there of moderate degree in that. So I would like to go for the diagnostic test for the pleural effusion, just to find out whether it is malignant pleural effusion, just to prognosticate and just to see that whether it will reoccur again and again. And so these two investigations I would like to go for first. And it is always better, as the Jordan sir said, to add a neuropathic agent also in these patients. What we usually do is that we always switch these patients to immediate release tablets, and this symptomatic relief also patient gets in case if we tap the pleural effusion so many times. So that will give a therapeutic as well as the diagnostic advantages to the patient. And I think it is always better to add a neuropathic agent as well. Plus, along with that, the patient is also having a PH2 score of 15, which is almost about moderate to severe depression. So we should always address this depression part also with the involvement of the psychiatrist, or even so we can also suggest him some antidepressants along with counseling.
Dr. Bablesh, you said something about optimizing calcium. That I will accept. You said if there is a pleural effusion, we can tap that. That I'll accept. Something else in between you said, I didn't catch you. What was that?
Diagnostic test of the pleural effusion.
Cytology.
Cytology of the pleural effusion.
Okay, fine. Okay,
Yeah.
so if there is a massive pleural effusion, you want to tap that, and you think that may be causing the pain.
Yeah, and just to check that whether the M cells are present or not, so that it will differentiate whether it is a malignant pleural effusion or not.
Okay, but not that it's going to make too much difference to our management. So most of the time, probably since I'm pretty much practicing in India, so most of the time I do cover a few oncology hospitals. Most of the time when these patients are referred for pain management, to tell you the truth, the oncologist is not planning anything much. So very little intervention you can expect from the oncologist once we do get referrals for pain and palliative care. So that's one. Second is, if it is really massive, yes, I accept that. We can tap. That's acceptable.
Actually, this part usually is taken care by the oncologist itself. They themselves tap and they do the diagnostic cytology.
Okay. So no, I'm just saying this diagnostic cytology is not going to make too much difference in terms of management.
Yeah.
Right. Can I call in Dr. Sunny here and ask him? So a lot of the specialists have told a lot of things. So everybody agrees that we have to optimize morphine dose. We talked about medicines to give to circumvent the side effects of morphine. We talked about antiemetics. We talked about medicines for constipation. Sunny, is there anything else we can add for
I have also a different opinion because I am doing palliative care along with the pain management. Whenever a patient is referred to us for pain management or palliative care, so we always say, I was a part of the panel discussion previously also, that healing begins with history. So first of all, when a patient is referred to, you have to listen to the chief complaints, which was already told. Certain things to be added, that goals of care are to be defined for all these patients, for all the cancer patients. Secondly, you have to find out whether the patient has been referred to you only for pain management, or he or she has been referred to you for total palliative care management. Thirdly, prognostication of the patient. Prognostication has been done by the oncologist or not. So you have to talk to the treating oncologist also, what is their plan for further chemotherapy or radiation and all. Next is what is the ECOG scoring of that patient, whether patient is bed bound or not. So the plan of action will change. You will go for the interventions if the ECOG scoring is 1 or 2, and if the ECOG scoring, the personal scoring is 3 or 4, that means the patient is lying on bed for more than 50% hours. So the whole soul will be the palliative care management. So before jumping into the interventions, what we also tell the patient, according to the reports and this ECOG scoring and prognostication, certain anticipated events for each and every patient are to be told after building a rapport with the patient. Like in this case, the patient is a diagnosed case of CA lung with vertebral metastasis. Mixed lytic and sclerotic lesions are present. Plus the patient is having hepatic metastasis. Moderate amount of pleural effusion is there. So certain anticipated events can happen during your dose titrations, or they can happen during the interventions too. So they include, like, patient can have a bone fracture because lytic lesions are present. Moreover, hepatic metastasis is present, so patient can have a raised bilirubin in near future. Thirdly, the patient is smoker, so might be having some COPD like of symptoms, so can have bronchospasm. Next is the patient is post-radiation. Post-radiation patient can have radiation pneumonitis, esophagitis and candidiasis. Even for oral thrust, sometimes patient comes to the pain clinic. So such events are to be told, because when you are doing these dose titrations or you are planning some interventions, even the surface blocks like the erector spinae or the paravertebral blocks, and after doing that intervention or going through the dose titration, if something happens, so the blame will come on morphine or these interventions. So this is one thing which I would like to add. Moreover, as Dr. Bablesh said, moderate pleural effusion is present. So definitely as a palliative care specialist, we are going for a cell cytology. After cell cytology, gram staining will be done. We will go for a cytology for malignant cells. And if malignant cells came out to be positive, so the prognosis is poor, stage 4 disease. So these things should be kept into mind. Moreover, because lytic lesions are present, so I would like to add that bisphosphonates can also be added for this bone pain. Because cancer-induced bone pain, the analgesics they usually include, first and foremost, is the non-steroidal anti-inflammatory agents, which are already been given. Secondly, morphine. Third, dexamethasone, already it was given to the patient. Moreover, neuropathic agents, these gabapentin or pregabalin, along with an antidepressant, they can be added. They can also help calm the patient, these palliative patients. And lastly, ketamine is also a role in this cancer-induced bone pain. So from my side, patient should have a dose titration. Morphine dose should be increased. And when you are increasing this morphine dose, you need to tackle, because he's on oral morphine, the constipation, which will happen in future. And zoledronic acid can be added if the creatinine is less than 1.2 and calcium is within normal limits. Over to you.
Okay, so 2-3 points he has raised. One is he said he'll have a chat with the oncologist. That is acceptable. Then he said he will explain the prognosis in terms of things that can go wrong. That is acceptable. Third is he said about adding neuropathic pain medication and some medication for opioid side effects. So yeah, more or less the line that is being suggested is okay. So in terms of palliative care, at what point do you...
Karthik,
Yeah,
I'm just interrupting. I
yes,
used
please.
to add something
Yes, please.
till now, whatever has been discussed. So, this is very basic. Whenever we are taking a class on cancer pain, the first things we start is what is the difference between a cancer pain and a benign pain, benign chronic pain. And we start with the terminology, and we teach. Long question also comes on what is called total pain. So total pain means only physical pain. If you're addressing, then we are not going to take care of them nicely. We have to take care of the psychological aspect, spiritual aspect, social aspect, financial aspect, all these aspects. And I'll be telling you one story, that yesterday story only. Yesterday only I talked with these patients, and all of us will be able to understand how important it is. So this patient was around 47 years old, a school teacher, senior lady, teacher of senior secondary school, and having an ovarian cancer with metastasis in the lung, in the vertebral body, some other areas exactly I can't recall. And the patient was having a lot of pain. Patient was going to some of the renowned cancer hospital here and there, and having a lot of pain, distress, and all those things. And at that point of time, they wanted to consult me. And before that, yesterday only, they have visited another doctor, another clinical oncologist, and he has given time. And when he was talking with me, he just listened carefully. That he was telling, till now I have, for this, apart from my cancer treatment, for this pain, I have visited 3-4 doctors, though none of them was a pain physician. All of them was some different oncologist only. And many of them has given, one of the doctors has given morphine as well, but he has not taken morphine. He has not taken morphine, telling that, okay, I have heard that once you are taking morphine, you cannot withdraw morphine. So I am afraid, so I have not started morphine. And I have taken the other drugs, but no pain relief. But today what happened, today my clinical oncologist talked with me so long time. He has offered me a cup of coffee also. And I don't know whether my pain is psychological or not. I am feeling much better. Today my pain is much better. But still, because I had an appointment, I am talking. But today I can tell you, after so long time, for the last almost 2 weeks, today I am feeling much better. Why she is feeling much better? The key point, she herself has diagnosed that the oncologist, clinical oncologist who has seen her yesterday, talked a long time with her, addressed all the different issues, offered a cup of coffee, talked so nicely, and she is feeling that her distress is much less than the last 2 weeks. So this is one very important area what we have to understand, that cancer pain is different from the other pain by the virtue of its concept of the total pain. A lot of other issues are also added, which is adding the sufferings. So you have to remember that. Not only that, another thing I used to mention, that many of our patients do not start morphine or other opioids just because we are not telling details about the morphine, what exactly it is, what are the bad effects, what are the good effects, what is going to happen, all those things we are not giving. So patients are afraid, they do not start opioid. So these are the few things. Most important thing, the message what I used to address, that already Sunny was talking a little bit about it also. I fully agree that you have to talk with the patients. There is no alternative with that. That will be taking care of these psychological issues, that will be taking care of the spiritual issues, all those social issues, and that is really going to help. But all other part has been covered nicely by most of the panelists here.
Right, thank you. I guess I'm not a very palliative person. Right.
I just want to add one thing. See, all of you know about Dr. Rajagopal from Trivandrum and his Pain Institute and Pallium Care. Needless to say, when you are seeing a cancer pain patient, you treat them as a whole. Any patient you treat as a whole. So sometimes, instead of jumping and making them see a psychiatrist, psychologist, just assess where they have been. Sometimes good pain control itself will bring their depression down. The most important thing, like the previous speaker and Gautam pointed out, is what does the patient want? I have a lady who is in her 60s. Believe it or not, she has survived ovarian cancer. She's had recurrences. She has meds everywhere. She fills up with 3 to 4 liters of water every 2 weeks. She somehow had side effect with every opioid. And remember, this is America, everything is available. So the only thing that suits her is tramadol extended release. So with meds in the liver, meds here, meds there, pain, chest wall pain, obviously, the first thing I would have offered her is an intrathecal trial and an intrathecal pump. But guess what? I could have put ziconotide instead of any of the opioids. But her plain and simple answer was, look, I think I'm taking tramadol 50 milligrams 3 times a day. I just want a little bit more pain control. They put in, like a little clip drain in her chest wall. And from time to time, they have a nurse draining her fluid from her abdomen. So her goal is very simple. I don't have to rub it in and tell her, hey, you are going to die. It is none of your business. Everybody's lifespan and what they want. The most important thing is you have to respect what the patient wants. So I give her extended release tramadol 100 milligrams twice a day. She was in more pain. I asked her, do you want extra? Her answer was, look, I'm taking lactulose. I'm constipated with this tramadol. I really don't want anything. I want my grandkids to visit me. I'm happy the way I am. So there is no point in jumping the guns or adding more medications. Your patient may resent you for giving her an extra pill like Lyrica or some other antidepressant. So the first and the most important thing is knowing what the patient wants and what the family wants. And family means the immediate family, or here we would say whoever is the next of kin or has power of attorney. Without that, you can't just jump and give them anything you want. And like Gautam pointed out, it is mixed pain. It is not simply nociceptive or neuropathic. It's a mixed type of pain. And see, the WHO ladder has changed. You can start at the first step with interventions. Okay, back to you, Karthik. I would stop talking now.
Right. I guess most of the panelists don't want to treat this patient conservatively with palliative care than get very aggressive in terms of advanced interventions. Right. So interesting to hear a lot of new views. So
I want to tell these things as well. So that it is not just for the palliative care. It's for any patient. We have to explain them. We have to talk them. Even if we are taking the benign pain, that is also these are important. But it is more important in cancer pain because they are having a lot of queries. Most important queries: why it happened to me? What are my problems? What have I done wrong? So these kind of things are there. So all you have to address all those things which are related directly with the cancer pain. It's not just always related with the palliative care. Even for the pain management, simple pain management specialist, we have to give time, and that is going to address many of the other things, including the psychological intervention. Best psychological intervention are done by a pain physician himself or herself.
And here you treat the patient, and you also have to make sure that, like Dr. Rajagopal has, a social structure for rehabilitation of the entire family and the age. And see, you can do all these interventions. I always have my fellows who want to jump in and do a pump. Remember, at least in this part of the world, the patient may die and pass away, but the big bill you still have to pay. So always be cognizant of the monetary situation, financial situation of the patient and the family. That's very important also when you provide a treatment.
One more thing I want to add. Interventions can be done. There is nothing no to interventions, but this pharmacology, it has to be continued, and interventions in especially cancer pain management, they are to supplement the analgesia of these pharmacological drugs, most commonly the opioids.
Okay, so point taken. So treat conservative, concept of total pain, support these patients mentally, and treat them with empathy. So that's the take-home message. Right. Anyway, for the sake of completion, any of the panelists think if conservative management or the palliative care does not work, there's a role for any interventions in pain? Dr. Joyshri, please.
You know, I differ with Dr. Sunny in one point. Okay, you cannot say that, no, you have to continue the medication. I have seen patients who have had meds. These days, medications and gene modification therapy, there are a lot of scope where the patient is well treated, well rehabilitated. And see, especially, I'll give you an example. I have seen several pancreatic cancer patients where they have had a pump initially. And now, you know, their pump is filled with saline. It's been 6, 8, 10 years since they have survived. It also depends on how well or aggressive is the multidisciplinary team. So if the patient had chemo, radiation, you're working with the oncologist, or they had a Whipple procedure, depending on the type of the cancer, they needed an intervention before they were still in pain. You put intrathecal morphine. It is possible for the patient to turn the corner, have a better quality of life. So I don't think we need to always say that, no, you need to continue medication, because some patients may get better and can be weaned off opioids. And one of the things with opioid crisis that MD Anderson had to do, which I have heard many times from my friends there, is this, that they had to have satellite clinics where after 5, 10, 15 years of taking some sort of opioids, the cancer was all resolved. You had to wean the patients off the cancer pain medication. Okay. As far as interventions, yes, you can do intrathecal pumps. Intrathecal pumps, you don't have to implant a pump. If you think the prognosis is just 1 month or 2 months, you know, you can hook up to a Portacath or an external, you can even have a small external infusion pump, which is a possibility. And that way the patient may have a better quality of life in terms of side effects, not constipation from if you are using morphine. The other thing would be, like, if it is the vertebral deposit, the lytic lesions, depending upon what the CT MRI show, you can even offer them RF of the lytic lesions. And you can even, after doing your RF, you can cement the vertebrae, which is a possibility. And let's say it was just the chest wall, you can try either a peripheral nerve stimulator or dorsal root ganglion stimulator. Those are all the wide options. But like everybody agreed, the first thing is, what's the history? Where is the main pain? What does the patient want? What can the family and the patient afford? Then you start your treatment and you add complementary treatment and other stuff. The thing that I exactly forgot to tell was, see, glial cell activation, that will be where any medication, there are medications in the pipeline which cause glial cell activation. If we have one such drug, it will replace most of the opioids. But in case of morphine, the glial cell activation, it actually represses the glial cell. So many of the oncologists would go for hydromorphone or some other drug because of this particular action of morphine. Okay, I think I covered a lot. Thank you. Over to you.
Thank you, ma'am. So probably, yeah, intrathecal morphine pumps are ideal, but not probably feasible in this part of the world, but we'll keep that in mind. Dr. Megha has put something about patient-controlled analgesia, some titration. Dr. Megha, can you elaborate on that? What would you like to do?
So we at Max have PCA pumps, and I'm sure we as anesthesiologists also have used patient-controlled analgesia pumps a lot. So analgesic titration, one way is to do it on an OPD basis with the immediate release morphine that everybody has mentioned already. That starts with immediate release morphine and then go up. So as a rule, when we start morphine, we mostly start, although this patient is already on 60 milligram morphine Q a day. So we'll go up from 10 milligrams every 4th hourly and SOS, and then ask the patient to maintain a diary as to how many extra doses are needed. Okay, so this is how the OPD basis analgesic titration would be done. And however, when we have patients admitted with us for analgesic titration, so we admit them, start the patient on a PCA pump, patient-controlled analgesia pump. It's a small pump wherein we fill, say, around 250 ml of fentanyl. 10 milligrams is to 1 ml. And we start the patient on a lower dose, and then they can take their extra doses. We set a lockout interval of 20 minutes, say, for fentanyl, and see after 24 hours how many extra doses, rescue doses the patient needed, and then titrate up. It takes around 2 to 3 days to finalize the doses that the patient would provide, that would provide patient adequate pain relief. Of course, along with that, our paracetamol and NSAID or anti-neuropathic medications, they go alongside, and other supportive medications like laxatives and antacids.
So essentially what you're saying is you admit these patients and give them an IV medication cocktail. That's what you're saying.
Yeah, yeah.
Okay, yeah, so that's acceptable, but yeah, most of the time these patients would probably prefer staying at home, so the transdermal or the oral routes are probably better, right? Anything else the panelists would like to add, or if I can sum up for the delegates? So
I would like to add one point.
Yeah.
Like as the patient is having breakthrough pain episodes, so the elaborate history of the breakthrough pain and even the evidence also suggests that there is a good role of oral transmucosal fentanyl citrate lollipops, which are easily available now in India. So we can also suggest, along with the immediate release tablets of morphine, that in between we can take opioids.
Can't hear you that well, Dr. Bablesh. Okay, I got the idea. So, okay, so essentially, having heard the history from Sumant, so most of the panelists seem to agree that you need to treat these patients with care. You need to provide total cancer pain care. So emphasis is more on palliation than on getting aggressive treatment. So the sort of treatments that the panelists have thrown up include supportive care, providing these patients with psychological support, making them know what's happening, keeping them in the loop in terms of prognosis, in terms of what can go wrong. In terms of treatment, the panelists seem to agree that we need to titrate the morphine dose in terms of opioid dose. Other opioids can be tried. Neuropathic pain medications do have a role in titrated doses. For the narcotics itself, we need to take care of antiemetics and for constipation. See how these patients are doing. Ideally, maintain a pain diary and see how these patients are doing. If with this supportive care, psychological support, bisphosphonates, calcium, so these things are also essential. With this, if these patients are not coming around, there seems to be a role for treating these patients with probably minimal, small interventions. The ones that Dr. Joyශ්‍රී talked about, paravertebral, intercostal, those are things that can be considered. If it is more lower chest wall, even splanchnic is an option. So these are the interventions we talked about, but ideally considering the situation and considering fairly advanced in terms of metastasis, probably interventions are not a great idea.
One thing Dr. Ashok also told, myofascial pain, these patients usually have myofascial trigger points. So trigger point injections can also be tried in such cases.
Right. And if none of this is working, there seems to be a role for an intrathecal pump. Intrathecal morphine pump seems to be a good option for somebody with cancer pain with extensive metastasis.
There is even an article on dry needling for myofascial pain in pancreatic cancer that was published by Dr. Lakshmi Bas. So, like I said, you can do all these supportive care. Sky is the limit.
Das sir, would you like to add something?
No, we summed up nicely. So that means this patient, particularly with lots of meds, supportive care is more important. The conservative management with the different analgesics, titrating the morphine and other opioids, the psychological support, and of course the different other interventions, whatever has been mentioned by all the panelists. So, but everybody agreed that the interventions is not a very good choice for this kind of patients. Here, the conservative management with this other supportive care is better than the interventions.
Right. Thank you. Good job, Dr. Sumant, for presenting a nice case. Keep up the good job. Now, can I invite Dr. Debjyoti to moderate the second patient, please?
So again, Debjyoti needs no introduction. He's one of the very important faculty at Daradia. And more importantly, one book is coming where his contribution is, great contribution. Book on musculoskeletal ultrasound in pain medicine. That is one of the very important book coming up. And we are hoping it to release during our ICSPCon. So, Debjyoti, are you there?
Yes, sir.
Okay.
So, let's start with the second presentation.
So, next speaker will be Prakriti.
Prakriti,
Yes,
please present your case.
Sir, I'm not able to share the screen, sir.
Okay, just a minute. Let me allow you.
Okay, now done.
Okay.
Sir, I'm starting, sir.
Yes, all right.
Okay, little introduction of Prakriti. Karthik, you have
Obviously, I don't have the PPT, but she is a Daradia fellow. And right now, she is one of the best fellows, actually. She joined recently. Karthik, I do not know. I don't have it.
Dr. Prakriti CM did her MBBS from Adi Chinchnagiri Institute of Medical Sciences, Mandya. She did her MD anesthesiology and from Mahadevappa Rampure Medical College in Gulbarga. And previously, she's worked in Columbia, Asia, and in Bangalore Manipal hospitals. And presently, she's doing a one-year fellowship in Daradia. Start, please.
A 42-year-old gentleman, he presented with chief complaints of upper abdomen and mid back pain since past 2 months. And presenting illness, the patient complains of diffuse upper abdominal pain till the umbilicus, which is insidious in onset, aching type for the past 2 months. The pain is intractable and constant since 2 weeks. The pain is severity in intensity, and NRS score was 9/10. It aggravated on taking food, lying down, and relieved by medication, sitting down position, and lying down in the curling position. And initially, but now the pain is partially relieved, and NRS score is 6/10. And the pain radiates to mid back and to the left shoulder sometimes. There is history of recurrent vomiting, loss of appetite, and significant weight loss, yellowish discoloration of the skin and eyes, itchy skin, dark colored urine, fatigue is present. There is no history of fever. Past history is a known case of diabetes mellitus, and he is on oral hypoglycemic agents. History of ERCP was done with stenting to biliary duct 1 month back. And the patient is a diagnosed case of pancreatic CA with invasion to the surrounding structures and metastasis. He was evaluated by the oncosurgeon, and tumor was inoperable and planned for chemotherapy and palliative care. And there is no history of any drug allergies. And his treatment history, he was on chemotherapy with gemcitabine and fluorouracil, and fentanyl patch of 50 mics per hour, and paracetamol 1 gram thrice a day. And he was on antiemetics and laxatives. Personal history, his diet is mixed, and his intake was poor. His appetite was poor. His sleep was inadequate due to disturbed due to pain. His bladder and bowel habits, he is constipated. And he's a chronic smoker and alcoholic, but quit since past 2 months. Family history is nothing significant. Psychosocial history, history of sleep disturbance is present. Anxiety and depression is present. He's married with 2 young kids, only working man in the family. He's unable to go to work, and there are financial constraints that are present. The PHQ-9 score is 13/27. It indicates moderate depression. General physical examination, a 42-year-old man who is poor built and cachexic, is conscious, oriented to time, place, and person, and his BMI is 21. Vitals are normal, and head-to-toe examination, there was yellowish discoloration of sclera and skin, and pallor present. Abdomen distended, and skin looks normal with yellowish discoloration, no visible veins, scars, or pulsations. Palpation, there was tenderness in the mid-epigastric region. Swelling is palpable at mid-epigastric region on deep palpation, and hepatomegaly and splenomegaly present. Percussion, there was fluid thrill and dullness present with mild ascites. Cardiovascular examination was normal. Respiratory system examination was normal. Neurological examination, higher mental functions were normal. And since he had backache, the back was examined. Inspection, the posterior gait was normal. There was no abnormal curvature of spine. Skin over back and lower limbs were normal. There is no muscle wasting or hypertrophy or fasciculations. Range of movements, there was flexion of the lumbar spine was painful, and extension, lateral bending, and lateral rotation was also painful, which was mainly due to the abdominal pain. And palpation, there was no local rise of temperature, no tenderness in the midline or paraspinal or SI joints, and no allodynia or hyperalgesias. Sensory examination to light touch, pressure, vibration, proprioception was normal in both the lower limbs. And motor examination, there was no rigidity or spasticity, and muscle power was good in both the lower limbs. It was 5/5. And deep tendon reflexes, knee, ankle was normal. Babinski sign was normal. There was no clonus. And special test, the Faber-Fair was normal. Straight leg raising test was normal bilaterally, and facet loading test was negative, and sacral thrust was negative. Investigation, CBC, the hemoglobin was 8.8 and platelet was 1.8 lakhs. And LFT, there was raised bilirubin levels and liver enzymes. The coagulation profile was normal. The creatinine was 0.9, ESR 40, and CRP was 1.8. And CT contrast, it reported heterodense lesion in the body and head of the pancreas, showing encasement of SMA artery and invasion with luminal narrowing and proximal dilatation of the stomach and duodenum, with peripheral enhancement into the liver, adjacent vessels, nerves, lymph nodes in porta hepatis, and in the peripancreatic areas that was suggestive of metastasis, which was stage 4.
So Though I'm a pain physician, but I don't want to get this type of patients in my clinic, and unfortunately, I get depressed too much. Anyway, so let's start with Sunny because he is doing a lot of palliative care. So, Sunny, are you here?
Yes, sir.
Okay. So, if you get this type of patient, what will be your next step?
Again, conservative. Because there are many things in this patient. I have written the history also. Mainly, the patient is having pain, which is starting from the right hypochondrium or upper abdomen, radiating to the back. So first and foremost thing, whenever you are taking history in such cases with CA pancreas, CA gallbladder, or upper abdominal malignancy, you have to take this history whether the pain is starting from the abdomen or the pain is starting from the back, because the line of management will definitely change with this history only. I recently got a patient who strictly said the pain is starting from the back and it is coming to the upper side, to the upper abdomen. So we went for a MRI whole spine screening of this patient, and what we found in CA pancreas, however, these bone metastases are not so common, and we found bony metastasis in that case. Secondly, we have to take proper history because healing begins with history. There is a proper thing which is written that the pain is increasing after taking the food. And the PET scan is saying that there is proximal dilatation of the stomach and the duodenum. So usually in these cases where there is CA pancreas, the second part of duodenum is compressed by the metastatic deposits. So these patients will get history of colicky type of pain. And there are likely chances that in future, these patients will have anticipated events like subacute intestinal obstruction. So this also should be taken into mind. Many times the oncologists have started pantoprazole with domperidone combination. So in these cases, domperidone, the bowel motility drugs have to be reduced for this type of colicky pain. Moreover, the patient is having jaundice even after ERCP. Stenting has been done, and again the patient is jaundiced. Patient is having itchy skin. Features of hepatic failure are present. There is fatigue. So I will not plan for any intervention in this patient at present. I will see the levels of bilirubin, whether they are going down or not. Moreover, paracetamol, it is in a dose of 1 grams per day, thrice daily dose. So if the patient is jaundiced, however, the patient is palliative, our main aim is to control the symptom, but this paracetamol should only be given in 3 gram daily dose for a short term, and it has to be reduced to less than 2 grams per day. Patient is having constipation. Although the patient is on fentanyl patch, that is good for all the abdominal malignancy. We have to titrate the dose with morphine tablets or IV morphine after admitting the patient, because IV morphine does not cause any constipation. This is how I am doing. This is my protocol at our center. And then we have to shift the patient to fentanyl patch. So this patient was on 120 milligrams oral morphine equivalent. Moreover, we also have to take care about the distension of the abdomen. Fluid trail was present as it was written in the history. For that, we have to take the help of the intervention radiologist, whether they want to go for single tapping, and if it comes out to be malignant cells positive on cytology, they can go for the pigtail insertion too. Moreover, psychological burden is very high. The patient is the whole sole earning member of the family. Patient is young, having 2 young kids, not able to go to work, so social isolation is present. So psychological counseling has a major role for such patients, being young and having a stage 4 disease. Lastly, as I said in the previous discussion also, I always make a rapport with the patient. I listen to the patients, and then I always tell the truth about the anticipated events, slowly and slowly. Common anticipated events for this per se patient are, because the disease is going to the duodenum and there is proximal dilatation and colicky pain after taking food is present. So there are likely chances that this patient can land up into subacute intestinal obstruction in future. It has to be told. If he will land up into subacute intercellular obstruction, there might be possibilities of electrolyte imbalance. And this electrolyte imbalance is also due to the poor oral intake of the patient. This has to be told to the family members. Because liver function test is deranged, there is likely chance that PT, INR and APTT will also go bad. So there are chances that the patient can have hematemesis or melena. Mostly in this case, because the upper abdomen is involved, so there will be nausea, vomiting along with the bleeding. Then as the disease progresses, there might be possibility of abdominal wall metastasis too. Moreover, if this bilirubin is not going down despite stenting, despite this ursodeoxycholic acid tablets or these Hepamus tablets, so there's possibility that the patient will land up into restlessness and agitation, that is encephalopathy like features. So it has to be told to the family members. And lastly, because you will go for a repeated tapping of the patient from the abdomen by the radiologist, so an external thing going into an immunocompromised patient. So there are likely chances that patient can land up into peritonitis. So he can land up into sepsis. So I usually keep these patients initially on conservative management. In case needed, you have built a rapport with the patient, or if this LFT is going down, possibility of going down is less because ERCP has already been done, then only we can plan for some intervention. Might be a celiac block or only a surface block. Usually nowadays I am giving erector spiny plane block for such type of patients. Thank you. Over to you.
Thank you, Sunny. You assessed the case very well and described the things as well. And here I would like to say only one thing. I have addressed the nausea vomiting, but what's your personal experience about olanzapine? Because it's a medicine which in this type of patients has shown good promise and used in some areas also. Have you any personal experience of that?
For such type of patients, I am usually using this haloperidol in low doses for this metabolic cause of vomiting. So olanzapine, I have not used much, but definitely in 1 to 2 patients only.
Okay. So, Dr. Lowry, is it there? Dr. Rohit? Actually, he is connected, but I don't think he is actually in front of. So, as Dr. Lahori is kindly, I think, is absent. So let's ask Dr. Bablesh. So, for the psychological management of these patients, what could be done?
For the psychological management, the best counseling is done by the pain and palliative care physicians. And the counseling should not be of the patient herself, but also along with the family members. So the caregivers should always be educated about the care of the patient, along with the patient per se, and what all the events are likely to happen near in about 1 or 2 weeks time. We should always educate the caregivers about that, and psychological support in all means, as the concept of total pain is there mentioned by Sir, should be addressed. As Sunny well mentioned about the financial crisis, he's the only earning member of the family. So in case if the facilities are there, we should, like in our institute, there are special social workers are there. We should make we should send these patients, or we should take the support of the social workers in case if something can be done regarding the finances of these patients, regarding the education of their children. So the support from the social worker, from the psychologist, and the repeated counseling, that he is not the only one. We are always there along with them, and we are standing in and each and every phase of their life. So I think that should be done. And for the psychological support, it is not only the drugs that can support, but so many things are there which can be supported to the patient.
Okay, thank you. Actually, talking therapy is very good, no doubt. But in country like India, it is very difficult to administer because I have a lot of psychiatrist friends and once I was a psychiatry resident as well. But in India, really, the patient load is so high that it sometimes becomes very difficult. So let's come to Dr. Medha. So what could be given in part of pharmacological management for the psychological support of this patient?
For psychological support, yeah?
Yes.
So I think a lot of us patients, for psychological management, not much pharmacological management that would be required, that we routinely use, unless it is such severe depression that we start on some antidepressants. Very unlikely, all the antidepressants take their around 1 to 2 months to start acting. So there is not much role of pharmacological management for psychological things. However, I would just like to add a little bit of things as to care of because there are a lot of things when we're talking about psychological things, care of the patient. One very important aspect is the care of the caregiver. That's one aspect we sometimes forget while taking care of the patient. So telling the caregivers, and as Dr. Babdesh mentioned, referring them to some social worker, like here we have some NGOs working for such patients who can provide some employment to the wife after he's gone and support education of the children. That provides good psychological support to the patient also, because one important thing that the patient is suffering from, after I go, what will happen to my family? How will they, once we are able to settle that, not just with talking, but actually doing something for the family, that is one very important aspect if you want to manage the psychological aspect in this thing. Another psychological aspect that must be mentioned is that the patient is scared of is that he will die in that pain, and he will die a bad death because he has cancer, and he will have a lot of pain, or he'll be really restless at the end of it. So telling them that we are there, and telling them that we will always be there for you, and put whatever symptoms you have, we will tackle them, and we will be able to tackle all the symptoms. So just telling them and reassuring that we are there and we will manage all the symptoms is really important. That really, many times patients not tell you such things, I'm scared of dying. So, but that helps them tackle that psychological distress.
Thank you. Let's come to Palak. Though in my practice, actually, when we got referral used to in psychiatry department, we usually add some antidepressant for those patients, because in India, talking therapy is not so easily available. So 2 drugs you commonly prescribed that time one was definitely the sertraline, and the other is definitely the escitalopram. Because these 2 drugs, the action comes very early. For the escitalopram, it comes something between 24 to 48 hours. The action starts actually. Anyway, but it is different according to the different areas, definitely. Let's come to Palak. So if we want any intervention for these patients, so what could be the intervention that could be possible for these patients?
Dr. Devjyoti, I'm sorry, I joined in the middle when she was presenting the history, so I could not go through the entire history of the patient.
Okay. So let's move to Dr. Jordan. Yes.
Deputy, before going into the interventions, earlier cases also I thought, but I missed that. What is the role of oral steroid in different cancer pain management? What is the scope in the earlier patient or in this patient? Because a lot of people there who are here in this panelist who are regularly managing the cancer pain, I'll be asking them that what is your opinion regarding the scope of oral steroids in managing these cancer pain patients? I'll be asking Sunny, Megha, Bablesh, you all are doing cancer pain management so nicely. So please give me your opinion regarding, is there any role? And if yes,
yes
how?
sir. Definitely oral steroids,
Because last patient also you forgot to mention these things, that role of oral steroid in managing, that is a part of conservative management.
Not only pain, sir, it also acts as an antiemetic. It also increases the appetite for such patients. So cancer-induced bone pain, definitely apart from NSAIDs and opioids, steroids can be given in a dose. Dexamethasone, we are commonly using 4 milligram twice daily dose. And it is to be mentioned on the case sheet that it is to be given before 5 p.m. Otherwise, it will hamper the circadian rhythm of the patient. So it can be given for 7 to 10 days, after which it can be tapered off slowly. Moreover, many a times we get patient like this patient, the patient was having fatigue as well as the patient was having cachexia and loss of appetite. For such patients, oral dexamethasone in a dose of 0.5 milligram twice daily dose at 9 a.m. and 5 p.m. will also act to increase the appetite, plus giving a certain amount of euphoria-like of thing to the patient.
I would like to add one point, like injectable steroids has a big role in spinal cord compression, and oral steroids has a role in case if the patient is having a raised ICP and the patient is terminally sick. So there is a role of 4 milligrams dexamethasone BD in case if the ICP is raised and the headache is not responding to the usual conservative management.
Dr.
I
Meera.
think one more indication of using steroids in cancer pain is, also subacute intestinal obstruction. So there also they help in reducing edema. If there's an intraluminal obstruction, they decrease a little bit of edema, and sometimes we give a trial of steroids in subacute intestinal obstruction too.
So another question to all three of you. If steroid is giving good results, how long can it be continued? Or when to stop it and again when to start it again?
So okay, I'll take it. So depending on the reason why we started it, say if we started for subacute intestinal obstruction, see if it's helping, along with, of course, steroids, there are many things that we start in subacute intestinal obstruction. So if it's helping, we say give a trial of 15 days, and if it's not, we taper it off. Similarly for, as an appetite stimulant, if we are adding, give a trial of 3 to 4 weeks, and if it helps, continue, does not, taper it off. So similarly for different reasons, when we stop and when we start the steroids, we taper it off accordingly.
Like she said, if you have started, like if I would like in the 4 milligram twice daily dose. So if you have given for around 7 to 10 days, you can reduce the dose to 2 milligram twice daily dose for another 10 days. And then further reducing by seeing the results, you can decrease it to 0.5 milligram twice daily dose. And it can be continued for even 2 to 3 months in palliative patients. Moreover, if like Dr. Bablesh said, it is given for the raised ICT. Recently, I had a patient, he is no more. He had all these features, leptomeningeal disease. So in that case, this dexamethasone, even if I am saying that reduce it or taper it off, the family was giving it and it was continued for till death for around 3 to 4 months. So it depends upon scenario to scenario, as Dr. Meera said, for what you have started, what is the prognosis of the patient. So according to that only, it can be continued. But on paper, you have to write that you are tapering it off.
Sometimes the head and neck malignancy has a orbital extension also. So these patients, they present with a lot of proptosis and orbital pain. So in these patients also, there is a role of oral dexamethasone, which is usually given in the dose of same 4 milligrams BD and can be tapered off over a 10 days or a 15 days period.
Okay, sorry, Debjyoti, for interruption. They can go ahead with their questions about the interventions.
Okay, definitely, because in fact, I only do the intervention part and rest I send for palliative care patients. So what are the interventions can be done, Dr. Ashok, because he is there throughout, I think.
Yeah, thank you, Dr. Debjyoti. There is a long list of interventions, and of course, they depend what resource you have, what experience you have, what type of patient you have with the comorbid conditions like Dr. Sunny Malik have already mentioned about the bleeding disorders in such patients. So we have to consider all these factors, whether patient is able to lie prone, what expertise you have in ultrasound or fluoroscopy. But to mention that we all know celiac plexus is standard. We can give diagnostic and later on we can give the neurolytic blocks. Alternative to celiac plexus, we have a splanchnic block, very popular once upon a time. But now, because with the advent of ultrasound, we can give anterior approach to the celiac plexus, so little less. Third, nowadays, previously like thoracic epidural, which was preferred. Now alternative paravertebral, and now more latestly, this erector spinae plain block. As Sunny had mentioned, there are many publications. I myself have used in 2-3 patients. This simply work wonderful to ameliorate the acute pain, and you have facility to give continuous by volumeric pump or other PCA pump. It does wonders without risking for the epidural or the invasive blocks like celiac plexus and expertise required like the splanchnic. So these are the interventions you can do, depending upon the patient's condition, the survival.
I think there is some connection problem.
Deputy,
Yes.
again, can you, on your behalf, can I add another question?
Yes, definitely.
Like earlier case, Joystree was talking about the interventions sometimes are done as a fourth step of the WHO ladder, which can be done at the beginning without going into the other trials. And we know that the visceral malignancy, the sympathetic block is having a very good evidence, and where the studies are also there, including our PN Jain's paper and similar other papers where the celiac plexus block is better than the oral medications. So I'll be again asking all the panelists here that with the pancreatic cancer pain, the conservative management with the opioids and the others should be coming fast, or the celiac plexus block or splanchnic block will be coming fast. What is the fast choice? Like in these patients or similar other pancreatic cancer patient, what is fast? Is it the intervention fast, or is it the medications fast? Because there is no hard and fast rule nowadays that okay, you have to try the conservative fast.
Can I answer, sir?
Okay, I asked
an open question.
Because the invention of the less or the least invasive like erector spinae, what I have found, these blocks not only help in the pain management, they help in the rapport building. Suppose you started, it will take some time to work. And if you start with little intervention like erector spinae, along with the medicine, I would not say which one the first. Conservative management is always the first. Then comes the intervention. But such interventions like erector spinae can be combined.
Dr. Jadam's internet connection is
not good.
Rapidly, you can develop a
Actually, his connection is not actually working. So in the actually something is going about erector spinae block. Lot of chats are there. So can anyone bring it
I
up
am
at the
also
top?
very much fond of this block. Erector
Am I audible now?
You are Dr. Jagan. The problem is you are audible, but your network connection is not good. So it is becoming very old. The record player when it stops feeding in a slow speed, it's becoming like that only.
I'm changing it to the faster one. I'm changing it.
It's like some drunken person is speaking.
Okay, sir. Okay, I'm changing it.
Okay, so Sunny was talking about the erector spinae block. So can you highlight on this matter?
I am also very fond of this erector spinae block, especially for this case. Why we are saying that celiac should not be given at first instance, because even after this ERCP and stenting, the LFT is deranged. The hemoglobin is 8.8. Moreover, I would like to emphasize on one more thing before planning for any sympathectomy. In the CA pancreas case, this patient was diabetic. So in one case, what happened, I did celiac plexus block. This was sympathectomy was done, alcohol neurolysis was given. The patient was having features of autonomic neuropathy. So post this sympathectomy, the patient was having VAS score of less than 4, but he was not able to sit. So especially for CA pancreas patients who are diabetic, always check before going for sympathectomy the HbA1c levels. The HbA1c levels, they should be less than 9. If they are much more than that, titrate their doses and see for the features of autonomic neuropathy. So this was one thing which I was telling. Moreover, the abdomen was distended. The patient was having fluid thrill. If at all you are going for the ultrasound guided block also, your medicine will definitely go to some extent dissolve with the ascitic fluid also. So for this case especially, a surface block will be better, as Dr. Ashok likely pointed. The erector spinae plane, even for end of life care patients, this erector spinae can be done under ultrasound guidance very easily at any point. And it has been mentioned in many case reports and texts that this medicine goes from the paravertebral space to the epidural space, plus to the sympathetic plexus and chain too. So it has a role for the abdominal pain management also. Even if you want a long-term management, patient is there with you, admitted. In that case, the same epidural catheter, it can be threaded under ultrasound guidance, and you can give a continuous infusion of local anesthetic along with some other medications. It works very well. Plus, in this case, because abdomen was distended, and this will happen multiple times, you have one more option. I have done in many cases. You can go for a tap neurolysis also. You can go for the upper abdomen bilaterally. You can go for the lower abdomen bilaterally. What you have to see in that case, that the alcohol concentration should be less than 33%. Only the sensory routes have to be targeted. So these two surface blocks, especially for the abdominal malignancy, they can do wonders apart from the conservative management for pain control. Erector spinae plane block plus a tap neurolysis. Dr. Ashok.
Among the three blocks.
Somebody was asking how long you can continue.
Yes, that was also a question. That was in the chat box, but anyway, you can answer that.
I have used for 44 days in one patient.
But what I want to address this point, that what is our message, take home message for the juniors? Like, say for example, this patient was having a lot of other comorbidities. Suppose this patient who is not that much of comorbidity, say for example, the hemoglobin is not that less, not that good glycemic controls. So evidence-based medicine says about the celiac plexus only, celiac plexus and the splanchnic nerve block only. So I feel whatever Dr. Sani, Dr. Ashok is telling, I fully agree. But what I feel is, the few cases cannot be an example for as a recommendations. Recommendation based on lot of other studies, lot of other the publications. So clearly, celiac plexus block for these kind of cancer patients who have the comorbidity. Again, what I fully agree that case to case has to be decided whether what is the risk versus the benefit ratio. That has to be taken care. Apart from that, the celiac plexus block is the choice, gold standard in the most of the literature, and that can be performed even before starting the conservative management. That also supported by lots of these things. The things will be for particularly for the juniors who is listening there. I'll be telling, okay, definitely this is say pancreatic cancer patient is one such condition where the celiac plexus block has a very good evidence, level 1 evidence. Of course, we have to judge about the comorbidities and the other risk factors.
Sure. So, celiac plexus or bilateral splanchnic neurolysis, these are, of course, really great things that we have for say pancreas or gallbladder and those things. However, they are better than on if done in early stage. When the patient is still ongoing cancer-directed treatment, it's better because there would be some effect on the cancer and that would be decreasing, and they last longer in that case. However, when the patient has exhausted all the cancer-directed therapies and is already on a very progressive stage, if we perform a block, so they usually, they would first they would require some analgesic therapy along with that. Okay, so the block majorly enhances the quality of relief that you are providing. One. Second, as the disease progresses, the pain comes back and the pain is still increasing. So maybe after around a month or so, the doses do increase, right? So that's the problem when we perform. And once you have put in a needle in a patient, the patient is like, after you 8 months baad to वापस से pain आ गया है. So you really need to be thoughtful about before you provide any intervention in such really advanced diseases, because ultimately आपको pharmacological management तो चलेगा. And so unless like Dr. Joshi was saying, like you're putting an intrathecal pump or something, so in that case definitely oral opioids go down and those things, but here in our scenarios we are not doing advanced interventions in such patients. That's my take on interventions in cancer.
If we are getting this such patients in the early course of treatment, definitely for visceral malignancy pain, as Gautam sir said, we have to go, we have a type 1 evidence, we have to go for this celiac plexus block. But many a times we are getting the patients in their advanced stage with so much of comorbidity, so much of disease progression. In that scenario, if you plan for any intervention, I think that surface blocks will be much better in that stage. But in early stage, definitely, as Gautam sir said, we can go for the celiac plexus block, and that is the best for CA pancreas patient.
Actually, I would like to add one point.
Yes.
Yeah, in the advanced cancer patients, there's a role of a surface block. So even there is a role of dry needling also in these patients as a substitute or an alternative to give a transient relief to these patients in case if we are not able to go for celiac or splanchnic neurolysis.
Okay, so celiac plexus is definitely an option because whenever possible, I try to put it because at least quality of life improves. Yeah. But definitely at the end stage, it is difficult to perform as well. The chances of success also goes down because apart from this visceral area, then somatic nerves also start taking the pain actually. So let's come to again Dr. Palak. So I'm not question. Yes.
Debjyoti, I just wanted to say, look on the history that was presented. There are a lot of para-aortic lymph nodes. Yes. You have to look at the CT scan. Everybody keeps repeating celiac plexus block. If your needle is going to pass through one of those nodes, you are implanting cancer cells. I find when there are a lot of mets everywhere, especially para-aortic lymph nodes, a safer option is splanchnic. You can do it at T11 or T12. And if the splanchnic diagnostic works, you can go in and immediately do an RF. And I've had several patients with pancreatic cancer. It helps with.
I have to mute her. No.
Okay. It helps not only reduce pain, decrease the amount of opioids. It's a wonderful block to do in whatever stage they are, provided they are in a lot of pain. Again, my whole thing about bringing this point up is, look, whenever you have these patients, it's good to say, I'll do this, I'll do that, but make sure that you go through the CT scans, MRIs, whatever you have. I did see that the LFT was elevated. Yes, good point. You have to make sure that the liver function is totally not off, that you're putting in a needle. But all said and done, in my scenario, if I saw enlarged lymph nodes all around that area, I would go up, and splanchnic blocks, believe me, work very, very well. So does splanchnic RF. And intrathecal pump, you don't have to implant a pump. Again, I repeat, if the prognosis is not that great, it's just a few weeks, you can externalize your pump and still provide good pain relief. Okay. And that's all I wanted to add. Thank you. Over to you.
Thank you. Actually, the fact is that sometimes it becomes difficult to put celiac plexus. In those cases, splanchnic is our option. And definitely, in one case, I thought initially I'll be doing an under ultrasound. I found that the mass around the celiac plexus actually. So I have to shift to the from the back actually. So these are the things when I was saying celiac, I was not actually saying celiac. Celiac, anterior, posterior, splanchnic, I actually think in the same way. Not much different. Let's come to Palak. Palak, are you there? No, she is not there, I think. She is not there. Okay, she is absent. So I think we have discussed everything except the pump. So,
Deputy, I'll be asking because a lot of juniors are also there. Just you ask some of the, the lots of experts are there. Just a little bit about the celiac and the splanchnic. Just a little quick review and the recapitulation, which will be, the particularly the young pain physicians.
Then I think who is the most intelligent person? I think Dr. Karthik is there. Okay, so let's ask him only. So just want you to give an overview of these two blocks.
I should say the clinical parts of doing a
celiac and splanchnic.
Tell you the truth, in between I was not there, so I don't follow the discussion, but I will answer this question. So splanchnic versus celiac, probably, see, pretty much we are blocking the same nerve. So the splanchnic, we are blocking the greater, lesser, and the least splanchnic nerves. In celiac, other than the splanchnic, the celiac ganglion, you're getting two more ganglions. So the celiac plexus, when we talk about, so this is the celiac ganglion, the aortorenal, and the superior mesenteric. Now, in principle, the differences between splanchnic, I probably have a bias towards splanchnic. I prefer to do the splanchnic, especially in chronic pancreatitis and also in cancer pain. Advantages being that they are well localized, so you can do an RF ablation. Second is the anatomy unlikely to get varied in splanchnic. So we may have patients with para-aortic lymph nodes. We may have patients with gross ascites. Very common to find patients who have post-operative. So surgery has been done, so the anatomy can change. So splanchnic is probably my preferred choice. So obvious advantages with splanchnic is anatomy is more or less consistent compared to celiac. You can do RF ablation. And third is, yeah, so these two are the main advantages. So in terms of posterior versus anterior splanchnic, it's pretty much always posterior. Celiac, you have a block option of doing anterior. So the anterior in my question, the question of anterior celiac comes mainly if you're worried about this patient not being able to lie down prone. So if you're comfortable with ultrasound, you can do ultrasound guided procedures. If your patient is having gross ascites or having a colostomy bag where they can't lie down prone, breathless in prone position. So these are the ones for anterior block. Of course, if you're very well versed with anterior celiac with chemical neurolysis, so that is considered. But probably given the options, splanchnic is probably my preferred block. Thanks.
Dr. Karthik, if the same problem like gross ascites, patient is unable to lie prone because of the colostomy bag or pain and ascites and lump, how would you settle that patient for even for a splanchnic in the prone position?
To tell you the truth, see, a lot of times when we talk about cancer patients, we say limited life expectancy, right? So a lot of times we say these patients may live for 3 months, 6 months. To tell you the truth, I also work in cancer hospitals. I'm not a very palliative person. I do only mainly interventional pain. But what I found is a lot of patients in which I did celiac with chemical neurolytics, or even splanchnic with chemical neurolytics, a lot of these patients live for very long, and this block only worked for 6 months. So even though it's cancer pain, but a lot of these patients actually had a very good, I mean, because a lot of these patients take palliative chemotherapy.
I think the question by Dr. Ashraf was how to position this patient.
Yes, I'm coming. I'm coming to that. I'm saying the reason why I prefer the splanchnic. So if this patient cannot be positioned prone, sometimes I do a lateral block. So I position these patients in lateral position. If you have reasonable expertise, lateral position can be used for splanchnic and for celiac. So that's something that I've tried. But if they totally can't tolerate even that, then you're left with only an anterior approach. And so if you're an anterior approach, it's only going to be a chemical neurolytic celiac block.
So another thing, I think this also I have seen sometimes it works, that putting soft pillow over the chest and the waist, making the abdomen free as much as possible. That also sometimes works. Otherwise, what you told, that is also very nice. That patient will be on the lateral positions. So the lateral view will be now AP view, and the AP view will be now lateral view. So in that way, you can put the needle also in some patients.
That's what I do most of the time. If they can't lie down prone, considering I prefer splanchnic, I do the whole thing in lateral. It's a little tricky than prone, but it can be done.
Question that is commonly asked by our juniors is about the neurolytic. Let's ask Dr. Palak, what neurolytic you prefer in those cases? Alcohol, phenol, and at which concentration?
So, Dipjyoti, normally I preferred 60% alcohol. So, if I take 199% alcohol, I dilute it. I take around 12 ml of alcohol and then dilute it and make a volume of around 20 ml. Or I can take 9 ml of alcohol and then make a volume of around 15 ml. If I'm making a volume of 20 ml, if I'm doing splanchnic, I may do on either side. If I'm doing celiac plexus, but preferably if I'm using alcohol, I prefer to do the celiac plexus instead of the splanchnic nerve block. Splanchnic nerve normally I do for the radiofrequency procedures. So yes, at celiac plexus, I can inject the volume somewhere around 15 to 20 ml.
So it's needle or in the transaortic approach?
I always go for transaortic approach.
And regarding radiofrequency, what are the parameters you use for the splanchnic?
See, my experience for the event we are talking about the cancer pain patients, I would prefer splanchnic nerve block or celiac plexus block or celiac ganglia block over the splanchnic nerve radiofrequency procedures. In my practice, so far I have done like as Kartik said, my experience with the cancer pain patient is also less. My patient's main common pool is chronic pain patient. But yes, I have done few procedures. Splanchnic now radiofrequency procedures, according to my experience, I have done only in chronic pancreatitis patients. So first of all, I do diagnostic procedures, or sometimes for straightforward also, I do immediately the radiofrequency procedures. That is at T11, T12 level.
Yeah, I would like to ask Dr. Kartik, you do all three or two, preferably T11 or 9, 10, 11, what you do for the splanchnic block?
Okay, this is pretty much individual preference. You have
RFA, I am asking, yeah. All three or two?
I do T11 and T12.
So two?
Two.
Lesser
and sometimes it's not, it is lesser or least, only God knows, but T11 and T12. So one thing you can do is, this is of course this is my own way of doing it. So if you have an option of if you are interested, sometimes you can do RF ablation in T11 very well, and then do celiac left side alone at L1. That is the one. That's something that I do. That's pretty much it. This is operator dependent. You can do it your own way. I sometimes like doing both. So I do RF ablation at T11 and L1 celiac alcohol neurolytic block.
Ipsilateral or opposite side? What side you do?
I start from the left and reach the upper border of L1. So I start from pretty oblique, so my needle needs pretty much the center of L1.
And how many lesions? Only one?
Oh, if you're doing RF ablation, I'd like to do at least 3 or 4 lesions on each side.
So I think we have discussed most of the parts except one, that is the intrathecal pump. So let's have Dr. Jayashree. Yes, madam. So I think it will be beneficial for juniors that you explain the thing, that intrathecal pump, especially starting from the test dose to pump implantation.
Sure. So the first thing is to find out what is the oral dose of morphine. We calculate everything on the morphine equivalent or MME. Okay. So let's say the usual conversion is 300 milligrams of oral morphine is equivalent to 1 milligram intrathecal. Sometimes, you have limitations like you don't want to put an intrathecal catheter or you don't want to do a spinal puncture. You can try epidural catheters, but for intrathecal sake, it is 300:1. So first thing is you calculate what is the dose. Let's say the patient is taking 300 or let's say 600 milligrams morphine milliequivalent. So that comes up to 2 milligrams intrathecal. Now, you don't pick up a patient and use the full 100% dose. The rule of thumb is when you trial with 40 to 50% of the dose. So here you will, if you are doing a single shot intrathecal trial, most important thing, patient history, lab work, all the good things. Like in this case, if it is a diabetic patient, I would have checked the hemoglobin A1C. I would have told the patient, hey, even though I'm giving you morphine, I want you to be sure that you check your blood sugars regularly, take your regular medication, etc., etc. So you admit the patient into a surgery center or in your case, a hospital where you can observe the patient at least for 4 to 6 hours. Okay. So usual prep and drape, intrathecal, single shot, 1 milligram, observe the patient to see how much is the pain relief. If the patient is on such high doses, considering it's cancer, not chronic pain, usually we tell them to take 50% of the dose the previous night or skip the dose in the morning. So at least you can get an idea of how much relief they have. There's another way. If suppose you have the insurance capability and the facility, then you can do a continuous infusion, in which case you will place a catheter like you are doing an implant, except that this catheter will be tunneled outside, hooked up to a PCA pump, which would be diluted in 50 ml with the 1 milligram morphine. This is just an example that I was giving, that you are taking 50% of the calculated dose. Our initial dose was 600 milligrams oral that the patient was on. And you will run the infusion, titrate, and run it over a period of 12 hours and see how the patient does. Okay. So that is how you do an intrathecal trial. When will you call a trial successful? The trial would be considered successful if the patient had at least 70-80% pain relief, minimal side effects. They were more awake, like when they are on excessive doses of morphine, they are fatigued, they are tired. So those are all the things that you will observe for. With morphine, with single shot, you also in these days, because of how there is a heightened opioid, what should I say, fear in the atmosphere here, you would also give, you can discharge the patient if it is a single shot after 4 hours, provided the patient's doing okay. You also give them one vial or a syringe of naloxone because sometimes they can have delayed respiratory depression. Usually you will tell the patient not to take any long-acting morphine on the day. You would give them like short-acting ones, and that too to be taken only if the pain is very severe, and have them keep a pain journal. That is the first step. And let's say the patient has excellent pain relief. If suppose you were doing an in-house trial, the advantage is if you have put a connector and you have tunneled the catheter, you can use the same catheter or you can throw that away. You have to prepare the patient for surgery. Again, pre-op checkup. And usually the pump comes as 20 ml or 40 ml. Give me 1 second. Sorry about it. So usually the pump comes at 20 or 40 ml, and the morphine either can be compounded by your pharmacy or in
Just can you tell also about the little bit about the mechanical pump and the battery operated pump?
Yes, I wish, I don't know if I can share my screen. Okay, I will tell you. See, there are 2 types of pump. One is the Medtronic pump and the other is Fluonics. Both are battery operated. With the mechanical pump, it is just that you exteriorize the catheter and you either place a portacath or you can use one of those infusion pumps that you have, like we give for regional blocks. But the main thing is you have to have the right setup. You have to know if there is a nurse. Here, in this case, the patient is either part of hospice or they have insurance. So we make sure that the wound is being inspected if it is an external pump, because infection is always a big problem, okay? And you calculate the dose based on your trial. So if you said 1 milligram, then you do 1 milligram per day, and that is with an external pump. With a battery operated pump, whether it is Medtronic or Fluonics, I haven't talked to the rep in the last few months, so I'm not sure if they are still around. One was a peristaltic pump, and the other is more, it has a valve at the beginning and at the end. Give me 1 sec. Let me see if I can. I will send you the pictures, Karthik, of both the pumps. Can you share it with everyone? I just did a...
You can share also. Just put the shares in.
Hold on. Give me 1 second.
Go on discussing the, summing up the things until he is ready, and then he can continue with the things.
I think she can actually share because I've seen she is co-host now.
Right, she is co-host. No, I'm telling, apart from what Dr. Jayashree telling, you can sum up the case. Jayashree, are you ready?
So, yeah, I am not able to share because I'm on my iPad. Okay, but
Yeah.
I promise I'll send you the slides, Gautam and Karthik, and Dev Jyoti, if I have your text. I think I have both of you on WhatsApp. So the difference is how these pumps operate. The big difference that they found in the last 4 years was there was a discrepancy in the Medtronic pump about the amount of dose that was delivered. So it was in excess of over 0.05 or 0.06, whereas the Flowonics pump was more accurate. But both the pumps are equally affected. Medtronic went back and modified it. The basic thing is what we use here. We use morphine, we use Dilaudid, and Ziconotide. Those are the 3 drugs that are FDA approved. But morphine, baclofen, and Ziconotide, but we also use hydromorphone because generally the consensus, polyanalytic consensus committee has approved hydromorphone or Dilaudid as a first line of treatment. So you calculate the dose, you place the pump. When you make an incision, you make an incision in the pump level, and usually you implant the pump right below the rib cage in the anterior wall of the abdomen, because it is a big pump, and even though it has become smaller than before, it's very uncomfortable for the patient to lie. So you're making an incision, one in the spine, one in the abdomen. You place the pump and you fill in the medication on the table. But what I would suggest, if you are a beginner and you're doing this pump, it is better to admit the patient for a day or 2, because you want to be sure that you are able to titrate the dose, decrease the oral dose, and make sure there are no other side effects. Then you discharge the patient. Of course, you will bring your patient back for a wound check in 7 days and then 14 days. Usually we mix Marcaine with morphine, which is allowed. Very rarely do we put anything else. You have to be conscious about what the FDA approves, but there are a lot of us who add clonidine, Marcaine, morphine or Dilaudid, and it is, some of the local anesthetics helps us with the neuropathic component of the pain. Okay. What else can I say? Once you implant a pump, you're practically like a stimulator, you're married to the patient. Okay. So you have to order your medication 1 week before the refill date. When you program the pump in the battery operated pumps, it will show you what dose it is being delivered. And usually 2 people have to sign before you make the change on the pump. And then you give a printout to the patient, you print it out and scan it into your electronic medical record. And 1 week before you order the medication, you always call your patient 3 to 4 days before for a refill, because the last thing you want is the pump to run out and the patient to go into withdrawals. So one big advantage of Ziconotide over morphine is you don't have any withdrawals. But again, Ziconotide, it works well in neuropathic pain, which is true in many cancer patients. But again, you have to know your patient well. You have to be sure no opioids are working and Ziconotide is the right choice. Ziconotide does have side effects, including hypotension, sometimes hypertension. You can have ataxia a lot, even though the patient has been on Ziconotide. Some patients can get delirious. So be aware of all the side effects of Ziconotide. Again, refill, program, have another witness, print out, sign, send it. Usually patients have had pumps for 7-8 years. The battery lasts from anywhere from 7 to 9 years. Okay, the Medtronic one. Any questions?
Thank you, madam. I think we have discussed 2 cases for 2 hours. I think it is time for sum up. So this is a very common type of case what we get actually. And for this patients, definitely if something comes, it's definitely the conservative management and management of the associated symptoms. Now, if the patient is not responding with the conservative, or Previously, the concept was when the patient was not responding, but nowadays you can start at least the sympathetic blocks early to give a better life for the patient. And definitely in the patient where the life expectancy is more, then definitely we can have this intrathecal pump, and it's a good choice. Thanks for joining us today, and especially Sani, Dr. Bablation, everyone in the panel also. I should not name individually because everyone has contributed a lot. Because for my practice only, I can say I am not doing that much of, I'm doing the procedure, especially when it is sent by the palliative care specialist, but I am not doing that much of medicinal management for these patients. But definitely, whatever you told will be helpful, especially for those juniors who are going to practice, especially the palliative care in future. Thank you for joining us today. And next week we have the ICSPCon, so I think next week there won't be any online discussion.
Thank you. Thank you.
We'll be meeting physically after years.
Yes.
And Happy New Year. Next week is Tamil New Year, Poila Boishak. So Happy New Year.
Poila Boishak. Yeah. Okay.
So good job, both the presenters, Dr. Sumant and Dr. Prakriti. And thank you to all the experts who joined us. And thank you to Dardia for arranging the meet. So thank you all. Stay safe. Happy weekend. Bye-bye.
Have a good weekend. Bye-bye.